Next, we'll invite Dr. Kiran. Yeah, welcome, ma'am. She's going to present a topic on the trigeminal postherpetic neuralgia from pathophysiology to the.
Thank you, chairpersons. At the outset, I would like to thank the organizing committee for giving me this opportunity to talk before you. I know I am standing in between you and your lunch, but I'll try to be very crisp and to the point so that I can finish my presentation on time. So, the topic of my today's lecture is trigeminal posthepatic neuralgia from pathophysiology to treatment. So, we have many sessions and lectures in the conference where they are going to talk about trigeminal neuralgia. So, I'll be focusing mainly on the postherpetic trigeminal neuralgia. So, this is a little bit about me. Okay, so this will be the outline of my lecture. Now, what is shingles or herpes zoster? Herpes zoster, it can occur at any stage in a person's life, and the clinical manifestation is because of the reactivation of a lifelong latent infection with the varicella-zoster. So, we all have had chickenpox early in our life, and so actually saying there are the patients all are can be patients for post-herpetic neuralgia if proper care is not taken whenever there is a suppression in the immunity or whenever there is a with the aging process this can occur. So it is always advisable to go for vaccines after the age of uh, either 55, 60. So it is an acute condition which affects the skin and the mucosa, and the varicella zoster it tends to be reactivated only once in the lifetime. So second attack is quite rare. It is less than 5%. Now, when this zoster it invades the trigeminal ganglion, it can lead to trigeminal herpes zoster, and this can affect the. I mean, the postherpetic neuralgia is most common in case of the trigeminal neuralgia. So, what is this virus? It is an alpha herpes virus that causes varicella infection, and then it becomes latent. So, after an episode of chickenpox, that virus it becomes latent and it remains in the neurons of the trigeminal ganglion or the dorsal root ganglion throughout the entire neuraxis. Over 90% of the world's population is infected by the virus, as I said, in the childhood. Now, whenever there is a decrease in the immunity, or either because of aging process or immunosuppression, this varicella zoster can reactivate and cause herpes, which is a dermatomically distributed painful rash, more than 1 million cases in US. And in India, the scenario is about 10.4 to 21.5% cases, patients who develop postherpetic neuralgia. So, quite a percent. Now, this out of all the herpes zoster cases, 10 to 20% are trigeminal herpes, which often leads to mainly the ophthalmic division, which is affected around 2.5 to 20% of all the cases. And the trigeminal, in all the cephalic cases, the trigeminal accounts for about 58%. Now, the pain associated with herpes, it is divided basically into three phases: the acute, subacute, and postherpetic, obviously depending upon the duration. So, the duration is highly variable, and about 50% of the patients they recover within the first year, and the pain usually follows the dermatomal distribution. Now, the most common complication of zoster is the postherpetic neuralgia, which is a persistent and it is a very debilitating and severe type of a pain which affects the quality of life of the patients. Now, herpes it accounts for about ophthalmic division accounts for the postherpetic neuralgia. As I said, it is most common in the ophthalmic division. The ophthalmic division accounts, the V1 that is, it accounts for about 75% of the trigeminal that is affected as compared to the V2 and V3 division. So it has a unilateral facial pain persisting or recurring for at least 3 months after the herpes and the distribution of one or more branches of the trigeminal nerve, and it may emerge in continuation with acute zoster and develop after a painless interval. So there is a suppression or a silent phase and then it can reactivate. Like I said, so it usually resolves within 1 year up to 78%, but it may remain about in 22 to 46% for 2 to 10 years. Now, coming to the pathophysiology, it is a highly contagious double stranded DNA virus of the herpes family. And the primary infestation, like I said, it is the basically chickenpox which occurs. The virus then it gains entry either in the trigeminal ganglion or in the sensory dorsal root ganglion. Then it becomes latent. It remains there silent for years together, and then it starts replicating and migrates in the sensory nerve endings along the dermatomal distribution, causing the dermatomal distribution of pain. The associated inflammation in the peripheral nerves, it leads to demyelination, Wallerian degeneration, and fibrosis. And because of this, the uninhibited and amplified activity in the unmyelinated primary afferents leads to the associated postherpetic neuralgia. So, mainly the pathophysiology that occurs, there is a scarring of the dorsal root ganglion and atrophy of the dorsal horn of the affected side. So, basically, this is the diagram where the varicella-zoster reactivation you can see. It leads to increase in the cellular response, and there is an inflammatory response, changes in the trigeminal afferents, which causes loss of nerve fibers and sensory innervation. There is a viral replication associated with inflammation and cell death causing hypersensitivity. So here you can see in this figure viral varicella-zoster reactivation causing inflammatory response, cellular remodeling in the trigeminal afferent C fibers, then and affecting the trigeminal ganglion. This trigeminal ganglion in turn also affects the second order neurons. So this is basically the pathophysiology. Now, why it is important to delineate the subtypes of postherpetic neuralgia so that appropriate therapeutic protocols can be laid down accordingly. So, in the study, Robotham et al. Quantified the sensory presentations and proposed 3 subtypes based on his research. So, there are basically 3 groups: the irritable nociceptive group, the central reorganization group, the deafferentiation group with ongoing pain. And the most common or the 50% fell in the subtype 2, where there was mechanical allodynia and thermal sensory deficits. Now, initially in the early stage of the disease, it is mainly the peripheral cutaneous nociceptors are involved, and later in the disease, it is the central nervous system, which is the central mechanisms are involved. Okay, coming to the clinical features, there is a severe pain. I mean, the patients can really, it is quite a traumatic experience for the patients. It is a deep burning, continuous, paroxysmal, lancinating, piercing, piercing pain along the distribution of the dermatomes. And it really affects their quality of life. There is usually numbness. So numbness is seen more commonly in the facial type of postherpetic neuralgia rather than the truncal. So there is affecting the face more. There is postherpetic pruritus, there is chronic itching frequently experienced, and also trigeminal trophic syndrome, that is the innervated tissue, there is associated tissue damage. Cerebral symptoms are more common in, of course, the trigeminal patients. They have 40% of the complain of insomnia, anxiety, depression, cognitive difficulties. Also, there is chronic fatigue, weight loss, anorexia, and allodynia, which indicates the central sensitization. Now, what are the management options? So, basically, it is divided into 3 zones. That is the preventive, medical, or interventional. Preventive, as I said, vaccines are definitely helpful, and after the age of 60, ideally everyone should take the vaccine. 60%, it helps in 60% prevention of the postherpetic neuralgia. Medical management, of course, I'll be discussing in details. The antivirals, tricyclic antidepressants, anticonvulsants, opioids, lidocaine patches. Capsaicin creams are not to be used in trigeminal. Interventional pain management like the peripheral nerve blocks, Botox, peripheral neurolysis, cryo, chemical neuroablation, and RFA. So, the prevention, of course, antivirals. So, usually during that stage, the patient does not reach us. It usually, a patient is in the periphery somewhere, some physician is treating. So, antivirals, if they are started early in disease within 72 hours, it is very beneficial. So acyclovir, famciclovir, and valacyclovir. This is the level A evidence. Level B is tricyclic antidepressants. They are very beneficial, like amitriptyline. And in high risk groups, either corticosteroids or nerve blocks are helpful. Now coming to the pharmacological management. So first line of management is usually gabapentinoids and 5% lidocaine patches. So needless to say, gabapen, we are all well versed with it. Gabapen and pregabalin, they have their advantages as well as the disadvantages. The second line of treatment are the opioids and the tricyclic antidepressants. And if the pain is refractory, then you go for IV lidocaine and NMDA antagonists. And of course, capsaicin cannot be used in trigeminal. Anticonvulsive agents like carbamazepine are again the first line in trigeminal postherpetic neuralgia. Now, these local applications like the capsaicin, etc., are not very much useful in these patients. So, you can use lidocaine patch, maximum of 3 patches per day, so that a maximum of in 12 hours can be given. So this is the protocol that is followed. Anti-epileptics like the gabapentin, tricyclic antidepressants, the opioids, topical agents like buprenorphine or transdermal patches of fentanyl, and 5% lidocaine gel, and anticonvulsive agents that can be started. Skin coolants and these have no role in trigeminal neuralgia. So there are certain newer drugs, and one drug is under investigation, DM 1796, which is once a daily tablet formulation of gabapentin, around 1800 milligram once a day dose. But of course, it is under investigation, and it is used, but it is under investigation, but with common side effects like dizziness, somnolence, etc. And venlafaxine, bupropion, and paroxetine have the analgesic effects, good analgesics, but whenever there is a side effects of tricyclic, only then they should be tried. Otherwise, tricyclic antidepressants are very good. Coming to interventions, so pain which is refractory to conservative management, of course, then you go in for interventions. Botox, it is a potent neurotoxin, and it acts by impeding the impulse transmission. So, although I am not very much well versed with Botox and I'm not using, we have certain other dhurandhars in our society who are using Botox for it. There are certain research articles where efficacy of botulinum toxin injection for the treatment of postherpetic neuralgia and pruritus was done. This was a case report, of course. A 71-year-old diagnosed with shingles in ophthalmic.
Last 2 minutes, ma'am.
Oh, 2 minutes only. Okay. So basically, he was administered the Botox after trying Gacerian ganglion, supraorbital, all these things, and they found it to be quite effective. This is a meta-analysis where the efficacy and safety of Botox was done in trigeminal neuralgia cases, postherpetic, and they concluded that it was quite efficacious and safe in treating trigeminal neuralgia. And of course, nerve blocks like our gold standards, peripheral nerve blocks where you can go in for supraorbital, intraorbital, depending on the site of the postherpetic neuralgia. Then efficacy of this was a study. It was a meta-analysis which was where they studied the ganglion RF thermocoagulation in moderate to severe post-herpetic neuralgia, and they studied 120 eligible patients, and they found out that there was significantly reduced VAS score and reduced serum IL-1 beta and IL-6 also. So, and they concluded that it is quite effective treatment and can be thought of in case of trigeminal hepatic neuralgia. Other interventions, like I said, RFA and pulsed RFA. Of course, this is another study where they studied RFA with dexamethasone and without dexamethasone. Another meta-analysis where they studied the efficacy of Gacerian ganglion high voltage long duration pulsed RF, and they concluded that it is quite effective and safe technique. So, coming to the take-home message, it is basically a neuropathic pain condition, and usually it resolves on its own, like I said, within a year or so. So, instead of going for deeper interventions like targeting the V1 division because that is again quite a dangerous thing. So it is better if you go for peripheral blocks, lidocaine patches, and pharmacological treatment. And peripheral blocks also work wonders. Thank you so much for the patient hearing.